welcome everybody. This is the Family Medicine Grand Rounds. Today is August 31st. For those who are claiming CME credit, we have posted here for you the activity code for today. I'll go into a little more information here in a few slides, but please just remember that if you are claiming credit, please do that before midnight tonight. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds. We are partnered with the South Central AHEC, and you can see our department mission statement there. Next slide. As we go ahead and get started, I want to just remind everybody, if you could please mute your microphone. Also, if you do have questions, please feel free to put those in the chat box, and I will be moderating during the session. So also just being attentive and engaged in the session, and then towards the end, I will also in the chat box be putting the link for feedback. Next slide. So for those, again, going back to the CME credit, if you are new, you'll need to first text your email address to the full toll-free number listed here. From there, you should get a confirmation code. Once you do that for each of the sessions thereafter, you just need to text attend and then the code for that day. So those things are listed for you, but if you have any trouble with that, please feel free to reach out to me or the CME office. Next slide. Also, make sure that if you are claiming credits, be sure to check out your transcript every so often, and you can do that by going to the CME office website listed here. But if you have any questions, feel free to give them a call, or you can reach out to me as well. Next slide. Also, for this presentation, we do offer to those members who are part of the AAFP, we do offer credits for this presentation as well, but any questions, again, reach out to them or to myself. Next slide. Also, we do like to mention that it is part of our goal in these FCM Grand Rounds to address the nationally established physician for core competencies that you see listed here. Next slide. And we just need to mention that Dr. Nguyen has no financial relationships with ineligible companies to disclose. Next slide. So we have Dr. Nguyen here for us today. She is an assistant professor in the ophthalmology department here at UT, and also the residency associate program director. And she's going to present to us today primary eye diseases.
All right. Hello, everyone. Thank you for being here, and thank you for having me. So the talk is kind of a long one. There's a lot of information, just because even though the eye is so small, there is still a lot that can go wrong with it, as many of you know. So it may seem a little rushed or fast, but like Nicole was saying earlier, I'm happy to stop for questions. So if anything comes up, I can't quite see everyone's hand, but maybe raise a hand or post in the chat, and then we can try to answer your question. So learning objectives today, we're just going to go over briefly the anatomy of the eye and the visual system, and then the meat of it will really be identifying causes of acute painless vision loss, identifying causes of chronic vision loss, causes of a red or painful eye, and then talking about some ocular manifestations of systemic diseases. So the eye anatomy, you guys may remember this from med school days, but if you think of the eye as like an optical system, you know, like a camera. So light comes in through the front of the eye, through the cornea, enters the pupil, through the lens, and then focuses on the retina. So the cornea and the lens act as lenses, essentially, to focus that light on the retina. The retina is the neurotissue that lines the inside of the eye, kind of like a wallpaper. And the smaller picture on the left is what you see when you look with an ophthalmoscope into the eye. You know, the red is the retina. So in terms of aqueous production and outflow, so the ciliary body makes aqueous humor. It travels from the posterior chamber around the lens into the anterior chamber and then through the trabecular meshwork. So this is particularly important in glaucoma. So basically glaucoma is when this equilibrium is disturbed. So either the ciliary body is making too much aqueous humor, the trabecular meshwork is not draining appropriately, or the trabecular meshwork is covered. And so anatomical impediment to outflow. So these are just other kind of more basic pictures with some anatomy here. So if I were to touch your eye, right, the cornea is the first thing I'm going to touch. And then behind that, you have the iris. The opening in the iris is the pupil, right? And then past that is the lens. So let's get into acute red eye, causes of an acute red eye. So here are kind of your most common things. So you can either have a subconjunctival hemorrhage, which, as you can see in that top left picture, can look really scary, but it's actually very benign. So the sclera, right, is the white part of the eye. The conjunctiva is a clear layer that sits on top of that. So blood in between these two layers is going to pool, and it's going to look like a subconjunctival hemorrhage. I always reassure patients that it's kind of like a bruise on the skin. It's nothing harmful. It's actually all on the outside of the eye. It's not going to cause any problems to the inside of the eye. And it should resolve on its own, just as a bruise would. And it can change colors, just like a bruise does also. Very common for older patients to get this. Their blood vessels are more frail. And then oftentimes they're on a blood thinner. So something as simple as, coughing a lot, sneezing, or just bending over, straining like a Valsalva maneuver, that can cause a subconjunctival hemorrhage. The patient will classically tell a story of, I didn't know anything until I looked in the mirror and it would just look like that. Or I didn't notice anything until somebody pointed it out to me, because it's not something that you're going to really feel or see until, you look in a mirror or somebody sees it on you. Yeah, and then conjunctival injection. So there's different types or different causes of conjunctival injection, and we'll get into that. So I kind of already talked about this, but the main thing with subconjunctival hemorrhage is typically there's no pain, outright pain. Well, sometimes the patient will say, yeah, it feels a little uncomfortable, or maybe a foreign body sensation, but there should not be any significant pain. The vision may be a touch blurry, but it should not be any significant change in vision. We talked about a Valsalva maneuver. Sometimes just like a little poke or something like that can cause that as well. And like I said, treatment, you just observe. If they're getting multiple episodes repeatedly, you may consider doing a workup just for like a bleeding disorder, but that would really be about it. So causes of conjunctival injection. So bacterial conjunctivitis is one of those. Typically these eyes will look really, really red, and the discharge will be really thick and really purulent. And that is going to help differentiate it from other causes of conjunctivitis, such as viral or allergic. Oftentimes you can elicit a history of a sick contact. You also want to think about STDs as a possibility. And in terms of treatment, obviously, if it was an STD, you would want to treat systemically for that STD. But in terms of the eye itself, usually we just give like a broad spectrum antibiotic eye drop, and then just really good hand hygiene so that they don't spread it to the other eye or spread it to somebody else. Viral conjunctivitis is another cause of an acute red eye. The eye is going to look red as well. And unlike bacterial conjunctivitis, this discharge is going to be more watery. So not that thick, purulent discharge. It's really not too painful. It really shouldn't be too much of a change in vision. Again, you can often elicit a history of a sick contact or a recent upper respiratory infection as well. The treatment for this, patients hate it, but it's really not much you can do. Just, I tell them, hey, it's like the common cold. You just kind of got to give it time and it'll go away on its own. So it's more like symptomatic relief. So cool compresses typically makes it feel better. And again, just really good hand hygiene, because the viral conjunctivitis are typically very contagious. So very common for viral conjunctivitis is they'll say, oh, it started out in one eye and then now it's spread to the other eye. That should trigger you to think more viral conjunctivitis than bacterial. And then allergic conjunctivitis, we see a lot of that here in San Antonio. The main distinguishing with this is itching. They're going to say it's really itchy. Again, the eye's going to look red. It's going to be more of a stringy, mucousy discharge, a little bit more mucousy than a viral conjunctivitis, but definitely not purulent like a bacterial conjunctivitis. Again, not so much pain or vision changes, just more the itching. And then a lot of times they'll have chemosis, which is where you can see in the picture on the right here, that conjunctiva just looks really, it's kind of bullous looking, almost like edematous looking. Again, oftentimes they'll have other, allergy symptoms, runny nose, sore throat from a postnasal drip, things like that, sneezing. And oftentimes you can elicit a history of like a seasonal timing. Oh, every time this year I get the same thing. There are H1 blocker, mast cell stabilizer drops that we can give the patients. Pataday or Patanol are going to be the common ones. Those are found over the counter, but a lot of times patients will just want you to write a prescription for it. Those are very benign. So even if you're worried that it may not be allergic conjunctivitis, it's really not going to cause any harm if you do prescribe that for the patient. Obviously, you would want to systemically treat their allergies as well. And then sometimes if it's really bad, you can give like a short course of steroid eye drops. So moving on to other causes of an acute red eye. So keratitis. So kera refers to the cornea. And then, so this is any inflammation of the cornea. You can have infectious causes. So it can be bacterial, fungal, acanthamoebal, or viral, typically HSV, or it can be non-infectious, so autoimmune causes. So both those pictures on the right, the white thing, I don't know if you guys can see my mouse, but the white thing on the cornea, that's the keratitis. That's what we're talking about. So this one here looks like a corneal ulcer, probably bacterial, but oh yeah, it says there bacterial ulcer. So signs and symptoms, this is definitely going to have decreased vision, especially those pictures I showed on the first slide. Those were pretty significant. They're going to have significantly decreased vision. So we're talking about, probably able to see you moving your hand, you're waving your hands in front of their face, but that's about it. It's going to be very, very painful. They're often going to come in with their eye closed, not wanting to open it. It is very painful. Part of that pain is from light sensitivity, which is why they'll come in with their eye closed and will be very sensitive to light. We talked about that corneal opacity. So that's that white on the cornea. The cornea is usually transparent and clear. Anytime it's not, that's pathologic. And then a hypopyon, which is this white here on this top picture, this white here. So that's a collection of white blood cells in the anterior chamber. So it's a keratitis or a bacterial corneal ulcer does not always have to have a hypopyon, but a hypopyon just kind of means that it's more severe. And then in really severe cases, you can have corneal edema or even melt, and that's what's going on in this bottom here picture here. The cornea has essentially melted or has become so thin at the top here that you worry about perforation. So with keratitis, usually there's some history of like contact lens wear, unfortunately, like with poor contact lens hygiene. So that means sleeping in contact lenses, swimming in lakes, pools, oceans with your contact lens in, wearing the same pair for months on end, things like that, and also obviously trauma. So treatment for these, you would definitely want to refer to an ophthalmologist, typically I would say same day, especially if it looked like that one on the bottom there. What we will do is we'll scrape it and send for culture, and then we start them on broad spectrum antibiotic eye drops. Depending again on how severe it is, sometimes they have to be hospitalized to have Q1 hour eye drops. So moving on to uveitis, so another cause of an acute red eye. So this is inflammation of the uvea. The uvea is the iris, the ciliary body, and the choroid. So signs and symptoms of uveitis, again, it's going to be decreased vision, pain, light sensitivity. You're going to see, so on exam, anterior chamber cells. We would see anterior chamber cells, I should say, but you may see what are called keratic precipitates. So this bottom picture on the right here, can you see all these kind of like white gray spots on the cornea? Those are called keratic precipitates. So those are actually on the inside layer, the layer of the cornea that faces the endothelium. So those are white blood cells that were in the anterior chamber and that kind of plastered along the endothelium. Again, you might see a hypopyon, which is this white layering at the bottom here. They may have an irregular pupil, like this patient does here, and that's from scarring. So either if the inflammation has been going on for a long time, or if they've had bouts of inflammation in the past, the iris scars down to the lens. And then vitreous cells is something that we would see on examination. So these are just a bunch of pictures. Top left obviously is a very severe case, but these are the keratitic precipitates that I was telling you about. This top middle picture is supposed to show pars planitis, so inflammation in the pars plana, and that's what you can see, like we call it snow banking. So it looks like kind of a white layer of snow there inside the eye. Picture top right is a hypopyon here. So you can see again this white collection of layering white blood cells in the anterior chamber. And then these are different ways that uveitis can affect the retina here, these bottom three pictures. So uveitis, the treatment is usually focused on treating the systemic condition. So for example, like CMV can cause it, sarcoidosis can cause it, ankylosing spondylitis. So a lot of co-management with rheumatology, often in treating uveitis that has an underlying systemic condition. The inflammation of the eye usually resolves with topical, so with steroid eye drops. But oftentimes, again, if the patient has some underlying condition, they're also going to need systemic management and systemic control of that condition. We can also do a cycloplegic for pain control. Sometimes oral steroids are necessary. And then, like I mentioned, if chronic, usually immunomodulatory therapy is necessary. So moving on, endophthalmitis is very serious. It's an infection of the entire eyeball. Presents with loss of vision, pain, redness, and again, a hypopyon. Again, this is inflammation throughout the eye. Every single part of the eye has inflammation. It can be bacterial, viral, or fungal. So it can be like from a trauma, or it can be like endogenous, like systemic, fungemia, something like that. Or it can also, you can have post-surgical endophthalmitis. That's obviously a very kind of the worst risk of any type of intraocular surgery, although exceedingly rare. Usually we have to do like intraocular injections for this. Sometimes if it's very severe, it requires emergent surgery. So moving on, so acute angle closure glaucoma, this is something that many of you are probably familiar with. And I just wanted to go over it just because there are some things to clarify and kind of clear up between angle closure glaucoma and open angle glaucoma. So angle closure glaucoma is the one that we typically learn about. So that's usually very painful. Vision is going to be decreased, and usually it's so painful that the patient is like nauseous. Like we usually see them in the clinic with like that brown paper bag. They're like dry heaving. It feels like throbbing pain in the eye. It's usually very, very painful. They have an increased intraocular pressure. That's what's causing the pain. They usually have a shallow anterior chamber. The cornea is usually going to be edematous, so it'll look hazy to you, like you won't be able to clearly see their iris color sometimes. And then oftentimes you'll see a mid-dilated and non-reactive pupil. So the treatment for this is eye pressure drops to lower the eye pressure, but the definitive treatment is what we call a laser peripheral iridotomy. So if you can see here, this little black opening right there, that's done with a laser, and it's basically allowing the aqueous another outflow pathway to prevent the pressure from rising. So I wanted to differentiate that between open angle glaucoma, because while angle closure glaucoma is, I feel like, what more people know about, it's actually fairly uncommon. Open angle glaucoma, typically when you're just talking about glaucoma, and if a patient says they have glaucoma, most likely they have open angle glaucoma. The other thing I wanted to mention is that you may notice that on a lot of medications that you prescribe, it may say, or the patient may ask you, hey, it told me to check with my doctor if I have glaucoma. Those medications are usually talking about if a patient has angle closure glaucoma, or is that risk of angle closure glaucoma. Usually those medications, almost always, I'm trying to think if there's nothing that I can think of that would be referring to, it's a contraindication to the patient who has open angle glaucoma taking it. The one caveat to that is steroids. So steroids in any way, shape, or form, usually if it's chronic though, can cause an increase in the eye pressure, which could put somebody at risk of developing open angle glaucoma. But so open angle glaucoma is the second leading cause of blindness worldwide. First is cataract. The major difference is that a cataract is a reversible cause of blindness, right? With cataract surgery, then they can see again. Glaucoma, however, is irreversible. So once damage happens, it is permanent. Treatment is really not so much treatment, but just to prevent further damage. Like I mentioned, it is the most common form of glaucoma in the United States. And unfortunately, it's often asymptomatic until late in the course when visual field loss is evident. So for primary care providers, when to refer somebody to be evaluated for glaucoma. So if they have a strong family history of glaucoma, obviously that is something then that all patients should be checked for. I would say, again, if it's a very strong family history, probably in their 40s, I think is reasonable. African American race is going to be a risk factor as well for open angle glaucoma. And open angle glaucoma is typically something that happens in older patients. So, not so much something that you're going to see in your teenagers, 20-year-olds, things like that. Back again, just as a reminder to this picture, right? So the analogy I always give patients is think of your eye as like a sink with the faucet always turned on, fluids always being made inside the eye, has nothing to do with the tears that you make on the outside of the eye, and the fluid's always draining through the drain. So some people, their faucet is turned on too much, or some people, the drain doesn't work, like there's some blockage distally that you can't see, or sometimes there's a blockage, something covering the drain. And usually patients can kind of understand that. So we talked about risk factors, again, age, family history, African heritage. Myopia, so nearsighted, is a less kind of significant risk factor. Diabetes is also a risk factor, and then thin corneas. We talked about the high eye pressure. You're going to see an increased cup to disc ratio. They'll have a visual field defect. So the visual field, the peripheral vision loss that you get in glaucoma is just that. It's a peripheral vision loss and kind of progresses inwards so that in patients with advanced glaucoma, they're going to have what we call tunnel vision. So it's just like they're looking through, just a very small tunnel of vision. These are some tests that we can have done in the clinic to monitor the patient's glaucoma. Again, the severity of the glaucoma is going to dictate how frequently we see the patients. Typically, patients with mild glaucoma only need to be seen probably every 6 months or so, assuming it's under good control. Patients with more advanced glaucoma may need to be seen as frequently as every 3 months. Something that you guys may be wondering as primary care providers is the patient has not seen their ophthalmologist in a while, got lost to follow-up, and they need a refill on their glaucoma eye drops. I would say refill the drops, give them a month or two supply, enough time to get back in the clinic. Because I would still rather have the patient using some type of, using their glaucoma eye drops until they can be seen. So the treatment for open angle glaucoma, most conservative would be eye pressure, lowering eye drops. And then we can also do laser procedures. And then for advanced cases, there's also surgical procedures that can be done. So going into kind of other common ocular conditions, styes, as you guys are familiar with. So this is just an acute infection of the glands on the lid margin. Usually it's staph. It'll be pretty red and it'll be, kind of painful and tender to the touch. So conservative treatment, you can have the patient just do warm compresses. So they sell like different stye treatments that you can tell them to get like over the counter, but there's like things that they can heat up in the microwave and then put on their closed eye. Or I just tell them to get a face towel, put hot water on it, and then hold it and kind of massage. You can give them a short course of antibiotic eye drops. That can help us a little bit. That can help a little bit as well. And then if it's just not getting better, if they're getting recurrent ones, then certainly you can refer to us and we can incise and drain it. So a chalazion is usually more chronic. It doesn't look quite as angry as the stye. It's an area of focal inflammation within the eyelid, again, secondary to obstruction of a meibomian gland. And again, you get this just like chronic localized swelling. Same thing, same treatment though, the warm compresses, and then we can incise and drain it if needed. So preseptal cellulitis, you may see this in the clinic setting or in an inpatient setting. So a preseptal cellulitis is infection of the tissues anterior to the orbital septum. So history, they may say that they had, some trauma to the surrounding area, maybe a bug bite or maybe a sty. With preseptal cellulitis, usually the vision is normal. It may be a little bit, just like a little bit blurry, but it should be fairly normal. They're not going to have an APD and they're going to have full extraocular movements. This can be managed on an outpatient basis. Usually we just do Augmentin or some oral antibiotics. You do want to follow it closely. I would say probably a couple of days, maybe have them come back, 3-4 days later to make sure that they're improving, give them really good strict return precautions if worsening. Because what you worry about is an orbital cellulitis. So now the infection has spread to the tissues posterior to the orbital septum. Again, you may elicit a history of trauma, oftentimes, especially in children and teenagers or young adults, they have bad sinus disease, bad concurrent sinus disease. So these patients will have decreased vision, usually just often the lid is so swollen that they can't really see out of it unless you lift their lid up. They may have an APD and they may have some restriction of their extraocular movements. So this does, unless you have like a super compliant patient, this almost always necessitates hospital admission for IV antibiotics. And then we get a CT, and if there's any subperiosteal abscess, it may need to be drained. Usually with IV antibiotics, again, assuming there's no subperiosteal abscess, after a couple of days, when you start to see improvement, then they can be discharged home on PO antibiotics. So moving on, this is a hyphema. So this is, we talked about white blood cells in the anterior chamber being a hypopyon. This is red blood cells in the anterior chamber. So that's called a hyphema. Usually this is secondary to trauma. So we're talking about a blunt trauma, very common, like a Nerf gun to the eye or being punched in the eye or something like that. You can have elevated eye pressures. With this, it's like I kind of tell the patients, you got to be on bed rest for at least the first few days, just because kind of moving around can cause a rebleed. It can kind of disturb the clot. And oftentimes the rebleed can be worse than the initial bleed. So bed rest, and then we treat them with topical steroids and topical cycloplegic. And usually we follow pretty closely. So if you were to see this, I would recommend, again, having the patient see an ophthalmologist. Again, depending on how big it is, that one on the bottom could probably wait until the next day to see an ophthalmologist. The one on the top, you'd probably want to send right away. But this can be managed as an outpatient, doesn't need hospital admission. Chemical burns, more likely going to see this in an inpatient setting. Alkalis are worse than acids because alkali can penetrate the cornea more. When you see this, you want to do copious irrigation. So they have a Morgan lens in the emergency room that they can put on the eye, and just basically saline just gets like flushed into the eye. And you basically want to just keep doing that until there are pH strips that you can check the pH until the pH is normalized. So obviously before, you would want to put in an eyelid holder, numb the eye. We always avert the lids as well, excuse me, to remove any particles that may be there. And then, like I said, you just continue irrigating until the pH has been neutralized. They'll need pain medications. It's often very painful. And then antibiotics, cycloplegics for pain, sometimes steroids. And then vitamin C and doxycycline help promote corneal healing. So oftentimes this will need to be inpatient, again, depending on how severe it is. So a corneal abrasion, this is a fairly common ocular condition that you probably will encounter in an outpatient setting. So the cornea is made up of the epithelium, Bowman's layer, the stroma, Descemet's membrane, and then the endothelium. So a corneal abrasion is a loss of the corneal epithelium. So trauma, like, oh, I was putting in my contact lens and I accidentally scratched my eye, or a finger poke from a sibling. Again, contact lenses, taking them in and out, a foreign body, many things can cause a corneal abrasion. The symptoms, usually they'll say it's painful. They'll feel like something's inside the eye. They'll feel like, I feel like it's something inside the eye. So a foreign body sensation. They may have some photophobia. They're going to have tearing, and they're going to have discomfort with blinking, because every time they blink, their lid is going against that scratch. There are fluorescein drops or fluorescein strips that you can use. And then with that blue light, the area of the corneal abrasion should light up green like that. So if you were able to do that and see that in an outpatient setting, and if it was small, it would be appropriate, I think, to manage on your own. You could do, you want to do antibiotic eye drops to prevent the abrasion from getting infected and turning into a corneal ulcer. You never, ever, ever want to prescribe them or give them the numbing drops. A lot of times patients will say like, oh, can you just give that to me? It made me feel so much better. And yeah, the numbing drop should get rid of their pain completely. But no, because the numbing drop, if used too frequently, can actually cause like more damage to the corneal epithelium. And then they wouldn't be able to tell because their eye would be numb. So never in any circumstances would you prescribe the numbing drop. So this, hopefully you would just see this in an inpatient setting. This is what we call a ruptured globe. So any laceration of the cornea or the sclera. This is usually going to be some type of either significant blunt trauma or penetrating trauma. Signs, so you may have, like on that bottom picture there, severe subconjunctival hemorrhage with chemosis. Oftentimes the pupil will look irregular like it does in that top picture. That's because there's a laceration in the cornea and iris tissue is coming outside of the eye. So it's pulling the pupil, making it irregular. They may have limitation of their extraocular motility, and then intraocular contents may be outside of the globe. So if this happens, you put a cover over it. You can put either like a shield, or you can cut out a styrofoam cup and just put it over. You don't want to put a patch on, okay? Because a patch can put pressure on the eye, which can cause more intraocular contents to come outside of the eye. So you don't want to put any like pressure patch, you just want to cover it. And then obviously this is an immediate ophthalmology consult. Okay, so talking about diabetic retinopathy next. Obviously something you'll have to manage and discuss a lot with your diabetic patients. So diabetes can, as you guys know, cause changes to the retina, occurs after prolonged elevated blood sugar levels. We classify it into non-proliferative and proliferative phases. The proliferative phase is worse. And the macula can also be involved in either the non-proliferative or proliferative phase, and it can cause swelling in the macula, so what we call diabetic macular edema. So the picture on the left is a normal retina, normal, beautifully healthy retina. Picture on the right is a what we would call severe, it looks like non-proliferative diabetic retinopathy. So you can see those little spots of bleeding. The yellow kind of star sunburst-like thing in the middle is diabetic macular edema. So the yellow is like lipid exudates. And so I think I have another slide on it. So yeah, so just more pictures of, bad cases of diabetic retinopathy. The one on the left, not so bad, but the one on the right, obviously very bad. And then proliferative diabetic retinopathy is when the blood vessels, they're not just leaking and causing bleeding spots, but new blood vessels like angiogenesis, new blood vessels are actually growing. So that's proliferation. The picture on the left, obviously we're just seeing a 2D image. If on our exam, we can see a 3D image, so we can see depth. So you see the blood vessels growing towards the inside of the eye. Just other pictures of horrible diabetic retinopathy. In really bad cases of proliferative diabetic retinopathy, so the picture on the left is what we call tractional retinal detachment. So we talked about that angiogenesis, the blood vessels proliferating, then they can contract. So that's that white stuff. And then when they can contract, they can pull the rest of the retina up, resulting in a retinal detachment. So in terms of screening for diabetic retinopathy, any patient with type 2 diabetes should be referred for screening. any patient with type 1 diabetes after 5 years of diagnosis. And then after that, they should be seen by an ophthalmologist at least once a year, and obviously more frequently with if they did have diabetic retinopathy. So treatment, we always tell them, talk to your primary care provider about controlling your blood sugar. As far as what we can do intravitreal injection, so an injection of an anti-VEGF into the eye. We can also do laser treatments, and then we can also do surgery if needed. So age-related macular degeneration. This is also going to be something that many of your patients will most likely have. This is a disease of older patients, so you're not going to see this in younger patients, typically at least over 50 years of age. I would say probably even over 60 years of age. More commonly in Caucasians, usually they'll have a history of smoking or are currently smoking, and a history of a lot of UV exposure. There's two forms, dry macular degeneration versus wet macular degeneration. So the dry form means dry because there's no bleeding. So drusen are, again, these like lipid and protein kind of deposits that happen in the retina, or you can have like atrophy of the outer retinal layers. So unlike with glaucoma, where we talked about patients getting that tunnel vision, macular degeneration, they actually have blurring of their central vision. So the patient might say, like, I'm looking at you, but I can't, like, your face is blurry to me, but their peripheral vision oftentimes is intact. So fortunately, macular degeneration is very debilitating because, as you can imagine, it affects your central vision. So patients are going to have a lot of trouble, reading, and it really is difficult. So the wet form, you get bleeding from the choroid. So the left is obviously the bleeding, and then the right picture is what happens when that bleeding starts to kind of get reabsorbed. So the treatment for the dry form, we recommend AREDS 2 vitamins, so like Preservision makes them. And you always want to do the AREDS 2. I don't even think they sell the original AREDS formulation anymore, but you want to do the AREDS 2. And that's usually just one capsule, like twice a day. And it's pretty benign. So, it doesn't really hurt to have somebody on that. It can make some patients like have an upset stomach. Some patients can't tolerate it. And if that's the case, then we usually just tell them to just take, a good vitamin that has, that kind of just a well-balanced vitamin. Smoking cessation, definitely if they're smoking, you want to encourage them to stop. And then for the for the dry form, unfortunately, there's no procedural or surgical interventions that we can do, unfortunately. For the wet form, there are intravitreal injections. So again, just like with the diabetic retinopathy, there's injections into the eye that we can do, and there's also some laser that we can do. But unfortunately, despite these, oftentimes the condition does progress and can be very debilitating. Wanted to talk a little bit about central retinal vein occlusions and central retinal artery occlusions. So central retinal vein occlusion, so it's caused by clot formation and obstruction of the central retinal vein. Usually patients will say just like, I was just sitting there and just boom, vision went out. There should be no pain with this. It's painless. And it should be very sudden, just like from 1 minute to the next, they lost their vision. On our exam, what we teach our residents is the retina has a blood and thunder appearance, and I think I have a picture of that. But yeah, so just a ton of bleeding. It can look, you may say, well, these look like the pictures of the diabetic retinopathy, and it does look very similar. The key, one way to differentiate is that in patients with diabetic retinopathy, the disease is going to be pretty symmetric between the two eyes, whereas with a central retinal vein occlusion, it's just going to happen in one eye. And so if you saw this in one eye and then you looked in the other eye and it was just a normal retina, that's going to make you think more of a central retinal vein occlusion. Whereas if you looked in the other eye and you saw similar spots of bleeding, that's going to make you think more diabetic retinopathy. Risk factors for this, so older age, hypertension, hyperlipidemia, diabetes, oral contraceptives as well, high eye pressure, smoking, and then obviously any hypercoagulable state. as far as when a patient presents with a central retinal vein occlusion, you obviously want to work them up for any of those above conditions I mentioned. And then we can do, again, treatment with injections or laser. Usually for a central retinal vein occlusion, just so you're aware, the prognosis, unfortunately, is usually pretty poor. Sometimes patients will get a branch retinal vein occlusion, so not the entire central retinal vein is occluded, but just like a tributary. The prognosis is better with that. So a central retinal artery occlusion is going to be more rare. It's occlusion of the central retinal artery. This is that cherry red spot you may remember. And again, usually the vision loss with a central retinal artery occlusion is going to be worse than the vision loss with central retinal vein occlusion. So with a vein occlusion, they'll probably still be able to see like the biggie on the chart. With a retinal artery occlusion, they may only be able to see light. It's usually quite severe. So you may remember the earlier pictures of the retina where the retina looked red. So this retina looks like that yellow-white, right? So that's because of either ischemia or edema. And then the fovea still looks red. So that's why we call it that cherry red spot. So sudden, painless, really complete loss of vision. And then those findings that we would see on exam. So risk factors, really anything that can increase emboli formation, atherosclerosis, cardiovascular disease, coagulopathies, collagen vascular diseases, older age, and it is more common in males. Treatment, I put these things up on there because they are, if you search them, you can see as treatment. But unfortunately, the reality is there's really not much to do for central retinal artery occlusion. Usually when the patient presents to the ER for this or something, like a stroke protocol will be initiated. But there's, by the time we see the patient, usually there's unfortunately not much to do, and the prognosis is very poor. So kind of like with the, the stroke protocol, you would get a carotid ultrasound, you can get an echo. In the right clinical scenario, you may want to think about giant cell arteritis. So you'd want to get ESR, CRP, a CBC as well. And then basically just, a good thorough review of systems. So retinal detachment, again, another common ocular condition that patients hear about. So that's a separation of the retina from the retinal pigment epithelium. So any tear or hole in the retina can cause a retinal detachment. And can really lead to severe vision loss if it's not caught early or treated. So symptom, flashes. A patient is going to see flashes. And when I say flashes, I mean with the eyes closed in a dark room, they can still see these flashes. So not like, oh, I walked down and it was really bright and I saw flashes. No, eyes closed in a dark room, you should still be able to see those flashes. Patients would describe it as looking like the flash of a camera or like a lightning flash. Oftentimes they'll have floaters as well. And we're not talking about just a few floaters here and there, but like hundreds of floaters. The vision will be decreased, or, if it's just kind of a partial retinal detachment, it'll look like, they'll say like a curtain is coming. Like, I can still see you here, but like this part of my vision is missing or something like that. And again, this should be painless. A retinal detachment has no pain. So these are pictures of what we would see on exam. That is a retinal detachment. So the picture on the right, you can see the bottom half, that retina is normal. And then that top half, that's the retina is detached. So again, it's bullous, it's elevated. And then the picture on the left, I think is just a zoomed in picture. And in it, you can find what we would call a horseshoe tear. So there was a tear in the retina, which allowed fluid to get underneath the retina, causing it to detach. This is a retina detachment that has been there for a very long time. Basically, you can see that it's like scarred. There's like the white is now like these fibrous membranes. So this would have a very poor prognosis. I should mention that if you have a patient who comes to you complaining of acute flashes and floaters, and you're worried about a retinal detachment, that I would refer to an ophthalmologist. Probably that day, really, as the studies have shown that a retinal detachment, usually the earlier the surgical repair, the better the prognosis. So if patients have a small retinal detachment and we detect it early and repair it early, they can have great visual prognosis. They can have 20/20 vision, for the rest of their life. So I mentioned it is an acute emergency. We can either do laser if it's just a tear or like a small retinal detachment. Obviously, if it's larger, then we would need to do surgery. So briefly talking about disc edema. So causes can be papilledema, optic neuritis, ischemic optic neuropathy, either arteritic or non-arteritic. So the picture on the leftmost picture is a picture of a normal optic nerve, although I would argue that that cup, the center part, is a little large, but a fairly normal optic nerve. The point is the margins are very distinct. So if I asked you to trace this optic nerve, you would easily be able to do that. These pictures here are of optic nerve edema. So you see how you can't really trace out, where does this optic disc, where's the outline, where's the margin of it, and same with this one. Yeah, and then so papilledema is disc edema that's caused by increased intracranial pressure. These patients may complain of like kind of transient blurred vision that can happen depending on their positioning. So like blurred vision when they're laying down, and then it improves when standing. They may have like a larger blind spot. Obviously you would want to rule out. So the first step when patient presents with this is we want to get an MRI to rule out like any intracranial tumor or anything like that. And if it's a normal MRI, then next they get a lumbar puncture. And if there's high intracranial pressure, then it's, pseudotumor cerebri or idiopathic, also known as idiopathic intracranial hypertension. So I should just mention, treatment for that is, acetazolamide pills, usually weight loss. If the patients are on oral contraceptives, that can be playing a role. So you may want to discuss discontinuation of that. In severe cases, they may need surgery. So we can do like an optic nerve sheath fenestration. So basically making little slits in the optic nerve sheath to release the fluid buildup. Or if they get really bad, headaches, they may need a shunt with neurosurgery or something like that. Optic neuritis will also give you disc edema. You'll have pain with extraocular movements. They'll have decreased vision, decreased color vision. They may have an APD. You can have anterior or posterior optic neuritis. You would want to obviously get an MRI brain and orbits. We treat this with IV steroids. If the MRI had white matter lesions, you want to be thinking multiple sclerosis. So in which case then we would ask for the help of, our kind of primary care providers. So ischemic optic neuropathy, you can have either arteritic, also known as giant cell arteritis, or non-arteritic ischemic optic neuropathy. So this is a very sudden, again, painless decrease in vision. If you're concerned about giant cell arteritis, so giant cell arteritis is typically going to be your older patient. They may complain of like pain here, like a headache here. Oftentimes it's like tender to the touch, like you push on it and they say it's painful. Other things they might say is like scalp tenderness. So you would elicit that, but like, if they are, like, yeah, it really hurts to like brush my hair or wash my hair. They may have like fatigue, unexplained weight loss, and like kind of like muscle and joint pains. If concerned about giant cell arteritis, you would want to refer to an ophthalmologist, pretty urgently. And usually we start systemic steroids right away and then plan for a temporal artery biopsy within the week. And then I think this is, wrapping up here. So cataract, this is kind of the bread and butter. So every single person will get cataract as they get older. Just the normal part of aging, just like getting wrinkles is what I tell patients. Some patients may not need surgery to remove their cataract, but everybody will get a cataract. So for a patient to say, oh yeah, I have a family history of cataracts. Everybody has a family history of cataracts. So a cataract, so when we're all born, right, we're born with a lens inside our eye. This lens is clear. As we age, the clouding of the lens or the opacification of the lens is what is referred to as a cataract. So these pictures here are showing very large or very significant cataracts. this is usually not what you see. Usually it's the patient will present prior to this point. You can have congenital cataracts, so important to check for red reflex in babies. Most cataracts are just senile or age related. You can have secondary cataracts, so a trauma can cause a cataract to grow faster. Diabetes can cause cataracts to grow faster. So unfortunately, in some of our clinics here, we see patients who are getting cataracts that need surgical intervention at the age of in their 40s because of really uncontrolled diabetes. Symptoms, so they'll have decreased vision. They'll often complain of glare. So usually one of the first symptoms that patients will say is that they have a lot of trouble driving at night. They feel like there's a lot of glare from oncoming car headlights or from like the street lights or traffic lights. These are just kind of different kind of types of cataracts. And this is, what we would see on our exam. The morphology or the type is not so much important. The treatment is still the same. And that is surgery. So there's no medical treatment for cataracts. There's no eye drops that will make the cataract grow away or slow down the growth of the cataract. There's really nothing the patient can do that's going to prevent the cataract from growing. Sun exposure does have some role. So, making sure you wear sunglasses when you're outside. Obviously, when the cataract is visually significant enough, then surgery is indicated. And when we take out the cataract, we always implant a lens inside the eye. That's how all cataract surgery is done. So it would be very unusual for a patient to say they had cataract surgery and a lens was not put inside the eye. Oftentimes, though, the patient may not know that a lens was put inside the eye, although they should get a little card. I was going to say, cataract surgery is an outpatient surgery. You don't need to stop blood thinners for routine cataract surgery. The patient can be continued on blood thinners. Oftentimes we'll need clearance from the primary care provider. So that's kind of why I'm just going over the exact logistics of cataract surgery. So usually they get light sedation, like maybe a little touch of propofol, a little Versed, a little fentanyl, but some patients are just, awake during surgery and that's fine. Some people will slightly kind of doze off, but it's under light sedation. Cataract surgery by an experienced surgeon typically takes probably about 15 to 20 minutes. The patient is laying flat on their back during that time. And then afterwards they go home same day. So when we're looking for clearance, it's mostly anesthesia wanting us to get the clearance, but making sure that there's no huge contraindication to them having cataract surgery, which most of the time there's not. Yeah, and I guess that's it. I know that was kind of a lot of information and probably pretty fast, but I don't know if there was any questions or if anybody has questions.
There was one question on here, I guess maybe to just, I don't know if there's a way to sum it up, but what are some basic physical exams that you would recommend for primary care physicians to detect or diagnose some of these conditions?
Yeah, that's a great question. So a lot of these unfortunately are going to be difficult, in terms of a physical exam. Even a direct ophthalmoscope, it gives you such a magnified view that you're only really able to see like barely any of the retina or the optic nerve at a given time. But just, I would say basic things like checking vision, as silly as that sounds. A lot of times, we get sent a patient or I'll get a call from a PCP and they'll say they have decreased vision. And then I'll say, oh, what is the vision? And they'll say, oh, I don't know. It was just decreased. So, just being like checking a visual acuity, and, you want to check the patient's visual acuity with their glasses correction on, and you want to check each eye individually. Something that kind of comes up is once the patient cannot see the big E anymore, which the big E is 2400 vision, there's still other ways that we can check the vision. So if the patient can't see the big E, the next thing we go to is what we would call count fingers vision. So you hold up fingers in front of the patient's eye at varying distances and ask if they can see that. So for example, like I would say count fingers vision at 3 feet or count fingers vision at face. So count fingers vision at face is worse then count fingers vision at 3 feet or 5 feet, for example. Let's say if they can't even see that, the next step then would be what we would call hand motion. So can they see you moving your hand in front of their eye? If they can't even see that, the next thing would be what we would call light perception. So can they see if you shine a light in that eye? And then after that would be no light perception. So for, there's still a lot of information that we can gather about the patient's vision, even if they can't read the big E on the chart. And a lot of times that helps us distinguish between, how serious a condition is as well. Other things are, just, using a pen light really, and just getting really close to the eye. Oftentimes you'll be able to see if the cornea is clear or if it's hazy. So like I mentioned, if the cornea is hazy, you won't clearly be able to see their iris. You won't clearly be able to see their pupil. Obviously, if they had like an infection of the cornea, a lot of those pictures I showed were really obvious. You'd see like a white spot, on their cornea. Other things to look out for would be, I mentioned like an irregular pupil. If the pupil is not, nice and round, not symmetric to the other eye, that may give you an indication to something going on. I think those are kind of the basic things I can think of. I don't know if that answered the question or if there are any other questions.
We have a few minutes left. I see someone also put, do you recommend fingertip tests for intraocular pressure?
Yeah, that's a great question. So unfortunately, just checking with your finger or palpating with your finger is extremely unreliable, and it's been shown to be unreliable even amongst like glaucoma specialists. So I would say no. The only time, obviously if you have no other way of checking the pressure and you're worried about that as an issue, what you can do is compare it to the patient's other eye or your own eye. So like if you close your eye and you kind of push on it, you can kind of feel how that feels. And then if you're pushing on the patient's eye and it feels like a rock, it feels much harder than that, then yeah, the pressure is probably high in that eye. But again, that's a very, very kind of poor man's way of checking the eye pressure. And it's been shown to not be very accurate or sensitive.
Hi, this is Palacios. Quick question, and you kind of alluded to this, but I often get patients that are getting ready to undergo some form of ophthalmologic procedure, mostly cataract, and they come in with a form that's asking for a whole gambit of tests. We know that procedure is considered low risk. How necessary is it for that testing?
Yeah, that's a great question. So at UT Health, at our institution, we don't ask for any tests to be done. We just, our form is just, do you clear this patient, for cataract surgery? So, I don't think really, cataract surgery, especially these days, is pretty straightforward, low risk procedure. So, I would probably treat it the same as you treat any other procedure where the patient gets light sedation. So I think like a colonoscopy is probably a good example. So if you're not recommending for your patients to get any kind of additional tests prior to a colonoscopy, I don't think they probably need any of those additional tests prior to cataract surgery. Now, obviously, if the patient had like, significant cardiac, history or something, basic lab work, most people don't require that these days.
Any other questions or comments? Okay, well, I don't see anything else in the chat box other than I did put in the link to provide Dr. Nguyen some feedback for her presentation today. And with that, just want to thank you. Thank you, Dr. Nguyen, for presenting today. And I hope everybody has a great day.
Thank you. Yeah, and I put my email address on there. Please, if you have any questions about the talk or you have a patient question or anything, I'm happy and I'm here to help.
Thank you so much.